All right, I know it's been a big day. You guys are hung in there good. We're almost done for the day. After this, though, anybody that has MSUD, and including those who have been transplanted, head over to the water fountain. We'll get the quick picture that we always get at each symposium. And then you're on your own for dinner. Of course, the restaurant is here in the hotel. And there's other restaurants a mile or so down the road. The hotel, if you're not real hungry, they just have a manager's reception with some free snacks and drinks. And then you're welcome to come back into the ballroom. We have a little mini carnival and just some fellowship and fun for the families and the kids. And certainly professionals are welcome as well. All right. Does anybody want to start us off? Oh, sorry. Is this for anybody in particular, any of the physicians in particular, or dietitian? Luis? Anybody? Okay. In an adult with classic MSUD, cerebral palsy, nonverbal status, and G-tube feeding, how would you think through repeated retching and vomiting that is triggered by waking up or fear, startled from unfamiliar people, ? Could this be cyclical vomiting, abdominal migraine, automatic dysregulation, anxiety, panic, response, dystonia, seizures, GI motility, or something else? Wherever I was looking at Kevin, I think.
Okay, good question. Difficult to answer. I would say, even though MSUD is not common, one of the things in medicine that we say is common things are common. So normally when you hear hoofbeats, you think horses, not zebras. It's a little different in this room. But when it comes to something like this, at that age, with cerebral palsy, by far and away, the most likely explanation would be gastroesophageal reflux, severe reflux, which would be really common in that situation. Things like abdominal migraines and dysmotility are not part of MSUD. So MSUD doesn't make you higher risk for those kinds of problems. And those are very rare, very, very rare. Also, I would think about something like some kind of a herniation of the stomach up into the diaphragm. But the first step would be to go to a physician, maybe a gastroenterologist, and the very first step would be some imaging studies of the upper intestines. Typically what's called an upper GI study, to see all the anatomy. You could see something like a hernia there. You could see reflux on that study. If that's not informative, there are other studies that can be done to look at the motility of the entire intestine. But this is sort of the kind of thing where it's like asking the mechanic to figure out what's wrong with your car without lifting the hood, right? You really need to do some diagnostic studies for something this complicated, but a good doctor will be able to do those in a way that helps you eliminate a lot of possibilities and get to the root of the problem. It's the best I can do without an MRI machine or an X-ray. So.
Again, with common things being common, constipation is always an issue. And so if you're not having like a bowel movement a day, that can really back up. Have you ever tried putting the G-tube to a vent? Where you don't necessarily attach a feeding bag to it, but you attach it to a bag and then hold it like above the level of the stomach and let air come out?
He actually uses a feeding pump continuously.
Continuously. And so I guess if you're seeing that this retching is happening more in the morning, if there is an ability to pause it and see if you can vent out air from the stomach and see if it makes him more comfortable. It might give you some ideas about what's going on too.
Okay, thank you.
The feeding tube goes through the stomach wall and sits in the stomach.
Yes.
Yeah.
Stomach.
So the other thing you want to make sure is that it's like positioned correctly. So that's why another good reason to do imaging, because the feeding tubes can slip and get too close to the pyloric valve at the bottom of the stomach, and that will make you retch a lot. And so it's just a mechanical problem. But that's the kind of thing you would see on this upper GI study.
Yes, it has been done, but seems like to be in the right place. But it's a mystery. It's still a mystery what's going on.
Hi, I'm just curious, and probably for Dr. Strauss, I don't know, with MSUD being so rare, and have you ever had an experience just kind of directing schools, or and like a better explanation for them to understand some of the support that our kids need at school that doesn't really fall under a diagnosis at times, whether ADHD or because they're too young, or autism. Like, I feel like we're kind of navigating that, so I'm just curious to see if there's any research data that can help the school better understand sometimes the supports that MSUD kids require that younger age.
It's a great question. I actually might not be the best person to answer this for the simple reason that I think what you're saying, what you're asking about, is a really important priority. In our experience working predominantly with the Mennonite population, they have their own parochial school system, which is significantly different than the public school system. What we did from our clinic, Dr. Meyer and other physicians, we went out of our way to educate our patient community about these things. We would have and still have what are called family days, where we invite families in much of this kind of forum at the clinic. They're informal days where we have these conversations with people. We talk to school teachers. We have community days for the school teachers to come in and learn. So I would simply say those are worthwhile pursuits. We have done it within our local community, but we have not engaged that way with the public schools.
Have you done official neuropsych testing? Okay. And how old is your child? She's 5. So it sounds like you're preparing for kindergarten? Yes. Okay. I find that the people that run the IEP process are very, and I'm sorry, that's an abbreviation that I'm trying to remember what it stands for.
Individual education.
Individualized education program. If you have formal neuropsychiatric testing, they should be able to translate that into the IEP. Have you had a chance to do an IEP review for kindergarten yet?
Yes.
Okay. And were you satisfied with?
I would say yes. I think really more of the challenge is the teachers understanding some of the behaviors and some of the supports that, I think they're trying to push a certain diagnosis because they don't understand MSUD. So
yeah.
That's really where
and I think that's where the neuropsychiatry testing is really helpful, to be like, no, you don't expect these things because we have formal testing, and you shouldn't anticipate that this is going to happen. And just trying to keep them on track in that way, because I think you're right. I think there are two ways that all of this education can work. It can work where the IEP is helpful in terms of making sure your child gets the supports they need, but it can also potentially put them in a box that you don't want them in. And so having the formal testing that maybe says that there are no differences is really what should be relied on, and the fact that you have it is really helpful.
Yeah, thank you.
Yeah, and also talk to your metabolic clinic. I mean, we often are online with the IEP just to explain MSUD and why you got to do this weird diet or not do this weird diet, whatever. So, you know, typically clinics are very willing to try and help, and you know, with telehealth or whatever now, we're able to do it pretty easily. So that's another option.
Things like having your metabolic clinic, having your dietitian reach out to the school nurse to do things like leave, low protein like snacks or special food for when the class, like a kid in the class has a birthday. I think is an easy transition, like because it sucks to be the kid that doesn't get the snack that someone brings in for their birthday. So if like the nurse has a stash, that's usually successful, and also makes them like then they definitely are not going to get the food that you don't necessarily want them to eat. Sorry.
When our son Jordan was younger, he really liked Swedish fish. That was his favorite candy, and we didn't really give it to him normally, but we kept it at school. So when there was a party and he got the Swedish fish, it was a big deal. And in the end, the teacher told me that all the other kids wanted the Swedish fish instead of the cupcakes. What should I do if my little girl has dry lips most of the time? Is this related to any levels of something I need to watch out for? I think you stumped him.
I can't say this for certain, because I would have to see what it looks like, or you have to take a doctor. But the only thing I would say about the lips is that that the lips are an area where you can show early signs of essential amino acid deficiency. So there's a condition called angular chelosis, which is some sort of chapping and dryness of the lips, particularly on the outer edges. And that can be an early sign of essential amino acid deficiency. So for MSCD specifically, I would make sure that's not the problem. And if that got more severe, you'll see more general problems with skin integrity. You'll see red rashes, skin peeling, scaling, and then it can lead to other significant problems. That's all I got for dry lips.
So, when our son broke his hip and had to go, we were in Lancaster General. It was such a much longer process for his metabolism to come back. Is there something that is out there in literature that we're making sure that all metabolic hospitals know how to deal with that old guy who's, the only thing growing is your hair and your nails, and you're just not able to get that leucine out? Because I know Dr. Morton did, when we were going through that, did say something to Dr. Strauss, but I didn't know whether anybody else has had this kind of issue. It's a very scary, long process to get Jeff back. Well, let's see, 47, 48, something like that, upper 40s.
I have a definite opinion on this one. So it is an intrinsic biological problem. We've documented it multiple times. Adult patients, it is much harder to get their levels down under all circumstances. In children, young children get sick more frequently. And so they tend to have more sick days. They tend to be hospitalized much more frequently than adults. And many of you have seen this play out in your own lives or your child's lives, that the frequency of hospitalizations and illnesses sort of tapers off. But it's a lot easier to get it under control in children than in adults. And the reason for that, as you've indicated, is that when you're an adult and your body has stopped growing, the only leucine you can tolerate, the only amount you can tolerate every day is what gets sloughed off from your hair and your skin and your fingernails. That's called insensible protein loss. That amount of protein is exactly equivalent to what you can tolerate in your diet. In children, they're growing very fast. So their muscles and their growing organs represent a sink for leucine. You can take advantage of that when you're treating them by giving them high dextrose infusions and insulin, and it pushes those amino acids into body protein at 5 or 6 times the rate you can achieve in an adult. And there's really no easy way to overcome that, actually, unfortunately. And this is why, we often say to people, well, people will sometimes think if I can just get through childhood, then the MSUD is going to be okay. Yeah, you're laughing, right? Yeah. My experience, and I'd be curious to know what Dr. Gold says about this, but my experience is it really doesn't get easier as you get older. It changes, but not necessarily easier.
And I think like there's a big difference between breaking your hip and getting a cold. Like you're also had probably a ton of muscle breakdown, and then the immobility is leading to more muscle breakdown, and so that turnover is putting people at a disadvantage too. I think some things get easier, but I think we're seeing a lot of differences in how symptoms present. That's physical, like emotional stress, sleepless nights is a lot more important than getting a cold. And that's harder to control too. And it's harder to say, like, I'm having a bad day at work, like, and I have brain fog, what is this from? So it's definitely changing, and I agree with everything that Dr. Strauss said about the fact that there's not a lot of places for your leucine to grow when you're bigger.
I was curious about the gene therapy a little bit. So, I don't know anything about it other than what you guys have shared today. But when we talk about the gene therapy, like if it works, but thinking of like the negative side effect, I guess is what I'm gonna ask. So, our clinic at one point tried like if our son was a thiamine responder to see if that would help increase his tolerance. And so you try it and it either works or it doesn't work. Is it the same way with the gene therapy that it works and it targets the right thing? And if it doesn't target the right thing, is there a downside to that, a negative effect, or it just didn't work? Does that make sense, what I'm asking?
It works better than thiamine, or we've got a problem. So it's a great question. So a couple of things about gene therapy, and I hope this answers your question. The intention with gene therapy is that with a single IV infusion, you essentially restore enough enzyme activity that is durable in the muscles, liver, brain, that would last you a lifetime, and that would essentially make MSUD go away. We don't know until we do the experiment if it'll be enough, if it'll work. And it is not a completely benign procedure. There are predictable risks with AAV9 gene therapy, some of which are serious and can be fatal. So like liver transplant, those risks are relatively uncommon. So there's been about 8,000 or so babies dosed with AAV9 in the newborn period. And complication rates are low, but when they happen, they're pretty bad. There's been a few fatalities. You tend to have 2 categories of risks with AAV gene therapy. One category is acute complications related to the inflammatory response or the immune response to the viral shell. So that's a relatively innocuous virus, but it's still a virus. And the number of viral particles the patient is receiving outnumbers the number of cells in their entire body. It's a huge load of virus. And so there is an immune reaction. And that typically that happens in 2 phases typically. The first phase is what's called complement activation. That is a very fast, early activation of blood components that can create blood clotting in organs like the kidneys. And that can be serious. The second phase is inflammation of the liver. Some what we call hepatopathy, liver enzymes typically go up. Most patients get a little bit of that, and almost all of them are asymptomatic. It sort of comes and goes like a wave, but they don't get sick from it. But rarely that can progress into liver failure. The absolute risks for those things are really low, but we take the dosing quite seriously. So all this to say, it's not like giving thiamine where, you're just tinkering around, and if it doesn't work, it's no big deal. It's a big deal. Once you give gene therapy, you can never give it again because the body forms antibodies against the viral shell that block you from ever getting it a second time. So it's got to work the first time you do it. Yeah. The other risk is a long-term theoretical risk, and that is if that little piece of DNA that you're adding sort of accidentally finds its way and inserts somewhere in your own genome, just by chance, if it inserts in strategically the wrong spot, it can activate a cancer gene and theoretically cause cancer. Out of the, again, 8,000 children who have been dosed, there's only one instance of that happening in a way that is probably a real side effect of the therapy. And that child was treated, developed a small brain tumor, actually. This was just reported about a week ago in the literature. And they traced it to an insertional event of gene therapy. The child was successfully treated and is doing fine, but that is a real complication. The one thing I'll say, I think, to sort of round out this answer is that it's certainly possible that we'll do the gene therapy and it will either not work at all, not cause serious side effects, but just not work. Or it will work partially, but not all the way. Or it will work for 5 years and then stop working. It is not mutually exclusive with liver transplant. So liver transplant is a viable plan B for people who want a cure, try gene therapy, and if it doesn't work to satisfaction, they can still get a liver transplant. Right, George? You're not going to cut them off? I mean, I heard you say it in public now. You're on the record.
Thank you.
In terms of liver transplant patients, are there any further advancements in immunosuppressant medications or immune tolerance therapies you see coming in the next 5-10 years?
Thank you. And who was asking that question? Great. So the question, what do we see in terms of immunosuppression changes down the road, and do we see that happening? The short answer is that immunosuppression overall is significantly safer than it was 20 years ago, both for children and for adults. Because it is, we're able to monitor against infections that were difficult to monitor for 20 years ago, where we had to more look for symptoms and signs of problems. Now we can empirically monitor for high things that are possible to occur, viral and other infections, and we can detect that before they cause symptoms. And so that's been the big driver for improved results and allows us to treat before we see symptoms. It also allows us to reduce immunosuppression. The status of modification of immunosuppression to allow immunosuppression-free transplant is not predictable at this point in time. There are trials with living donor liver transplants to give some type of immune agent in cells that will allow the reduction or elimination of immunosuppression in controlled studies. We were doing one study like that in our adult population in Pittsburgh, and it's a safe therapy. It removes a certain type of cell called a dendritic cell from the donor a week before the transplant of the living donor segment to the patient. And that has had some preliminary results that have been encouraging. But we don't know exactly. It's difficult to fund those studies as well, and the applicability for patients right now is limited to a small sample right now. So I don't anticipate a large change in immunosuppression in the next 5 years that would be applicable broadly speaking. But having said that, I think that there's the management of this in a good center with good follow-up with compliant patients, I think has reached a high level of safety right now.
In my clinical experience doing follow-up for Dr. Mazariegos' patients over now more than 20 years, consistently the fear of immunosuppression is way overblown relative to the actual real-world risk with liver transplant. In other words, it's a predominant concern that most people have going into the transplant, but actual immune-related complications after liver transplant are exceedingly rare in my experience. Patients really do very well and have very infrequent and usually mild complications.
I have a question for Dr. Strauss, if I may, related to gene therapy. And what is your estimation of the reverse of what you said, the ability to deliver gene therapy to a patient who has had a liver transplant? And the reason I ask that is that, as you know, when we've collaborated on trials, we worry about fibrosis of the liver. We want to deliver agents into as normal a liver as possible. Most of our patients, we would expect to have normal liver, but there may be some fibrosis. And so what is the status of a transplanted liver not allowing a patient to have types of gene therapy currently?
I'm not accepting questions from other doctors today. So, that's an exclusion criteria. So, it's a great question. So, I think the simplest thing to say about it is it's totally new territory. So, with gene therapy, we're creating new biology. It's completely new biology under the sun. So, to answer a question like that, there's so many different variables that would be hard to guess about. Having said that, there's nothing in principle, there's nothing a priori that would preclude somebody who got a transplant from getting gene therapy. And in that setting, your principal target would not be the liver. It would be to deliver gene product to muscle and brain. One of the interesting things that came up, I think, in conversations yesterday is that I can envision a world where people get a liver transplant, still have some mild chronic neurochemical disturbances that can be corrected with gene therapy directed directly into the spinal fluid at a much lower dose. So again, I don't see them as mutually exclusive. I see a way to utilize both together, but we still have to get past some sort of proof of concept to get to that stage.
I will just also state that the presence of some anti-inflammatory, anti-rejection medications may actually make those patients tolerate the therapy better.
They actually almost certainly would. So one of the, there's now good evidence from gene therapy trials that sirolimus and tacrolimus, drugs that you routinely use, do provide significant protection against the immune response to gene therapy. And in fact, in our gene therapy trial in infants, we'll be using sirolimus as an immune suppressant.
Sometimes see with adults who've been treated for one cancer and have more chance to get another one.
Thank you. So the question is there evidence that transplantation in infants leads to a higher incidence of lymphoproliferative disease or other cancers as compared to adults? Two answers to that. One is the incidence of EBV, which is Epstein-Barr virus lymphoproliferative disease, has decreased in the pediatric population. So it's about 2% for liver recipients now. And this is significantly down from earlier when we started the transplant experience, it was more in the area of 8%. Patients who, and this affects children in general more than adults because they are EBV naive in most cases, and they don't have EBV antibodies as adults more likely to. So they, in general, for all indications, had a higher incidence than adults. But this is now decreased to very low levels. We've had one patient with EBV PTLD that's under treatment right now, and one with the majority of these are managed by reduction of immunosuppression changes. So it is a low incidence. Still something that we are looking for, but it's not at a level that is a real concern. The adult patients who are immunosuppression in adults or children who transition into adult care and grow, they do need screening protocols for malignancies that do present at higher incidence than the general population, predominantly skin lesions, skin cancer. So that has a higher incidence in patients on immunosuppression. So we do instruct all our patients to use skin care, to have regular skin follow-up, for malignancy, particularly the young Amish population that has sun exposure, et cetera. But all patients are counseled in that, and as adults, that type of screening for skin malignancies is important. Other follow-up like colonoscopy, GYN follow-up is more in line with typical adult surveillance programs. So that doesn't have there's a slight increase in that, but not a significant one that has been an issue for adult patients.
Yes, I have a written question here. What should a written sick day diet plan include for an adult with classic MSUD who has repeated vomiting or retching in order to prevent catabolism and metabolic crisis? At what point should we check amino acids, ketones, or go to the ER for IV dextrose? So my first comment is, if you are, even as an adult, if you're going on a sick diet, let your clinic know, because they should know that you're out there ill and going on a sick diet. I mean, one of the red flags of being on a sick diet is vomiting that won't stop. I mean, that is a big red flag. That means that sick diet is really not doing what we're intending it to do, which is to give more calories and low leucine intake. So definitely let your clinic know. And my other comment is, sometimes the physicians will prescribe, there are some medications that prevent vomiting, but that's a case-by-case basis. And really, if vomiting is happening and it's not stopping, you really need to let your clinic know. They might say go to the ER, or they might make some other changes, but really that is a big red flag with the use of sick diets.
Did you have a question back there? You're holding a microphone.
Is it on? Okay. Well, interestingly, our son did get PTLD, not followed by UPMC though, and he was treated it was caught early, and was treated with rituximab and is doing great. But my question was, for having kids that have been transplanted, is there a reason that you can think of that they should continue to be followed by a metabolic doctor, a benefit to that, or because you had mentioned maybe seeing a patient that had been transplanted, so I didn't know if there was a real benefit to this child in still being followed by a metabolic doctor if there's a concern.
I have a somewhat controversial opinion on this question. I think the first thing to say is it depends on who your transplant surgeon is. So, you know, I really trust their team and feel like they can handle it. I would say that from a metabolic doctor point of view, I would probably like to see a little bit more amino acid data post-transplant than we get to see. You know, we generally know the levels are quite stable, but they really start to dwindle off over time. We just don't, a lot of the transplant centers don't even order amino acids after a while. You would think, I would say, they should keep seeing their metabolic doctor, like just in case, you know. But the point, in my view, of doing something like a transplant is to demedicalize the illness, right? A big thing that we're trying to achieve is to give that child a more normal childhood and life. And normal, healthy children don't go to 5 doctors, right? So to the extent that we can have confidence in the stability of the procedure, I really advocate for trimming down as much of the medicalization of a person's life as you possibly can. I think it's a really important goal. And it's difficult because when you raise a child with MSUD, you psychologically cling to that disease and it's hard to let it go as a parent. It's harder for you as a parent to release it. Your child doesn't want to go to the doctor. But it's okay to release it.
I have just a quick comment to that too. I agree with Kevin. And one of the practical nuances that's important to consider is the other levels of care that can be provided. So in the Clinic for Special Children, the dual benefit is that the pediatricians and care providers there who are following the patients are doing so primarily to manage the medical aspects of care. So they're working as our partners, following the liver care and the blood pressure and the transition of care issues for the adults, and they're also able to monitor the annual follow-up. So we have a clinic coming up next week with Grace and her team, and they're great partners from the metabolic point of view, obviously, but also they're really doing the key work of being the primary care physicians for their team. If in other situations where we don't have patients from the clinic who are MSUD patients, they are typically not seeing their metabolic care, but they're getting the pediatric care with another care provider. And so when they come to see us in Pittsburgh, it's usually for the hepatology and liver care point of view. And then we only involve the metabolic team if there's a rare concern.
Am I the last one?
He's got one to read. We got probably a couple more.
Oh, okay.
We're good.
So far, we've heard transplants, gene therapy. We all know about formula. What else is on the horizon? Is there anything else that's being researched? Maybe a medicine you can take when you eat your meal, or something with the pancreas, or some other organ in the body. What else is out there?
I can take this one. So as a starting point, yes, there are other things. There are at least 2 things that you'll almost certainly see in the next couple of years that are promising. AAV gene therapy is just one kind of gene therapy. Gene therapy is an umbrella of molecular therapies. As I often say, AAV gene therapy is like penicillin. It's changing medicine forever, but it's not going to be the last word on gene therapy. In the same way penicillin didn't solve all the infections in the world. So there's going to be massive improvements in gene therapy delivery systems. There's going to be gene editing systems coming online in the next 2 to 5 years. And there will probably be non-viral ways to deliver genes that are much safer and cheaper and easier. So keep an eye out for that. It's hard to forecast because this field is moving so quickly. But you will almost certainly see alternatives to the gene therapy I was talking about. The other thing that I'm excited about that we were talking about today is there's a relatively simple and elegant oral medicine that's being tested in PKU that actually blocks the reuptake of certain amino acids at the level of the kidney and allows the kidney to excrete large amounts, in the case of PKU, of phenylalanine. That's shown to be quite effective in PKU and quite safe. And it should, in principle, the same drug should, in principle, work for MSUD because the branched-chain amino acids share the same transporter in the kidney. And so, I'm actually really jazzed up about that. I think it's a really cool drug. It's actually based on an insight that there's an inborn error of metabolism called Hartnup disease, which is an inherited deficiency of that transporter in the kidney. Described, 40 or 50 years ago. And patients with Hartnup disease excrete a lot of amino acids in their urine, and they have moderately low essential amino acid levels, but not low enough that they get sick from it. So it's basically an asymptomatic problem. So this drug is actually giving patients Hartnup disease on purpose to fix their PKU. And it should work for MSUD. So keep an eye out for that one.
Can you read that one before again?
Yes. Has there been any research into extracting the enzyme complex BCKAD from a plant or animal source that could be used as an alternative therapy? This is a great question. So the short answer is yes. There has been efforts to engineer bacteria that actually have a high capacity for metabolizing the branched chain amino acids and then populating somebody's microbiome in their gut with these bacteria. So you basically set up a factory in the inside of somebody's intestines that metabolizes branched chain amino acids. And it doesn't work. It sounds too good to be true, and it is. And we're not really sure why that is. It may be because these bacteria can't sort of outcompete the natural bacteria that are there, so over time they just go away. I think it has more to do with the quantitative capacity. You can't get enough enzyme activity to really take over for what the body can do. So it's a great idea, but it doesn't work in that setting. There is something called enzyme replacement therapy, which is done for many metabolic disorders and is very successful. So there's a whole class of metabolic disorders where patients go into the clinic each month, they get an IV placed, and they get a recombinant intravenous form of the intact enzyme infused into their bloodstream. It lowers their chemical levels for about a month, and then they have to go back into the clinic and start all over again. The reason that hasn't been attempted for MSUD is because, remember, the enzyme complex is not one thing. It's 4 subunits locked together in an extremely complicated configuration. And it's actually not just 4, it's 4 different types of proteins, but there's more than one copy of each of those proteins. So the intact MSUD complex has something like 24 different proteins locked together in this very complicated structure that is well beyond what you can build to infuse into the bloodstream. So you would almost have to genetically engineer or bioengineer some other new enzyme that would do the job, but which is possible. Are you thinking about how to do it already? I think you are. But right now, it's really not feasible. And people are moving away from enzyme replacement generally because they feel like gene therapies are going to offer a more durable one-time solution.
Over here, is this working? It says regarding the metformin and weight loss study, was metformin able to bring down leucine levels as well? So per the data, the answer is no. We were not able to prove that the metformin brought down the leucine levels. Anecdotally, there were a lot of low leucine levels during the study, to the point that we had to have a protocol addendum to subjectively allow patients to eat a half gram extra intact protein for low levels, so below 1.5 milligrams per deciliter, which would be, I am so bad at public math.
Public math, I like
Yeah, so what, like 111, 110? Yeah, 110 if you go by that scale.
It's like 180.
Okay. So we did have to tell patients that they could eat more because their level was too low. However, the diet diaries never proved that they were eating more. So you have to kind of take that for what it is, and patients are definitely welcome to try metformin, and it is safe, and see what their experience is in terms of their leucine tolerance and their leucine levels.
We have time maybe for one more that's a short question. Yes, and then he's going to run, or David's going to take the microphone over.
Hi, I was wondering if any of you guys had any experience with post-transplant with the leucine levels and the allo-isoleucine levels being heightened for months at a time without any sickness, disease, anything, stress or anything causing that, with an already reduction of natural protein.
Kevin, do you want to address that? We've had intermittent self-limited, and then we've had one patient that was referred who was a living donor patient that recipient from their mom that had very frequent episodes of hyperleucinosis that eventually were mildly associated with some symptomatology, but eventually resolved. That's my only experience with that.
Yeah, I would agree with that. I don't have as much direct experience, but I've been sort of following this problem. So I would say that, as George indicated, we certainly have documented some infrequent cases where episodically the leucine can go up and can get actually quite high transiently, usually in the setting of severe dehydration. It also characteristically corrects very easily. So you rehydrate the patient with just some simple salt solution, and it usually comes right down. I would say if you have a persistent elevation of allo-isoleucine and leucine, I would be suspicious that there's some problem with the graft, that the surgical procedure is unsuccessful, either because of some blood flow problem with the graft, some primary graft failure, or, as George indicated, maybe the donor liver was a partial MSUD case. I would genotype the donor liver, actually.
Okay, because we actually just had his first biopsy, and it looked beautiful from that aspect, like no issues whatsoever. So that our team is just kind of thrown through a loop. But now thinking of that aspect, yeah, that would
have him run genetic MSUD genetic testing on the liver biopsy. I mean, it's possible for intermediate patients to completely escape detection for years. And it happens. There's been patients reported who first had a crisis when they were in their 30s, and they had intermediate MSUD their whole life.
All right, a round of applause for our professionals here for their knowledge and wisdom. That concludes the things for today with the exception of the picture. So make sure you head out over towards the fountain, and then we'll get the picture of all those with